those of you who don't know me, I'm Rich Lord. Trying to figure out all these new titles now. I'm at Wake Forest School of Medicine as chair, and then enterprise chair for Atrium Health. And we have Atrium Health Wake Forest Baptist, Atrium Health Charlotte Region, those types of things. And this topic came out of our Committee on Healthcare Transformation this fall, and we started feeling like that, we've got to get back after a lot of the COVID stuff going on to begin to get back into thinking about other stuff. One of the things we've been talking about is hospital at home and sort of how that's beginning to pop up. It's starting to happen. Certainly it's happened at Wake Forest. And I felt it where it bumped into some of the population health stuff. We weren't aligned. It was siloed a little bit. And so we felt like it would be a good topic to have folks who had actually really stood up a program out of family medicine, could kind of help lead and talk through, and then have us talk through as a group sort of issues we may be facing that we can help one another around, or how we might need to consider standing us up, and maybe hopefully learn from any failures that the Charlotte region has had, so we don't repeat the same issues. So David Slauson is regional chair down in Charlotte, and I'm going to turn it over to him to introduce the group that has kind of created the hospital at home program down in the Charlotte region. So Dave.
Thanks, Rich. Yeah, this I'm not going to talk more than a minute because I'm going to let these guys talk, but this all kind of came about right within a few months of the pandemic. We'd all known each other, but it really, the story's pretty remarkable, and the effect that we've been able to do with this has been even more remarkable, and the growth and what's happened. Many of you probably seen there's been a fair amount of randomized trials, even poems that our group has written about comparing the same patient being randomized to hospital at home versus going to brick and mortar hospital, and the outcomes are actually better when they go home. It costs less, their quality's better, the satisfaction's better. So there's a lot of really good evidence behind doing this, and I will let them tell their story. Colleen, you're going first, right?
It might make more sense just to give context, but I know Dr. Brown has to get off. What time do you need to go?
No, it's perfectly fine. Actually, one of my patients canceled, so I'm good. Yay.
Okay. I'm going to talk a little because the main show is my colleague. So you want me to start, Dave, or you want to introduce?
So, Colleen, I'll just introduce you real quickly. Colleen is she's the main sort of hospital at home administrator. She's a BSN, Master of Health, our chief nurse executive, and Colleen has really is the force behind getting all the folks and training everybody to go out there. And so I will stop talking, let Colleen go.
Right. So I'll put your seatbelt on because I'm going to talk pretty quick, but I thought it might be helpful just to tell you how we got to where we are. As Dave and Rich Lord said, this was really a response to the pandemic. So literally on March the 13th, I was called to a meeting as we anticipated a capacity crisis in our health system, which already in even normal times, particularly in the winter, we're over capacity anyway. So tsunami coming, we immediately began to muster existing resources. So fortunately at Atrium, we had a lot of things already in place. We had, and partly because we had shut down or were getting ready to shut down endoscopy and some primary care, things were backing off, I should say. We had providers, nurses, and a pretty robust team of community paramedics already on board. And our intention was to deliver hospital level care, not home health on steroids. So we mustered our resources. We quickly wrote clinical protocols and workflows. For example, how do you admit a patient? How do you transfer a patient from brick and mortar? How do you discharge? All of those protocols for nursing to follow for care escalation. We developed eligibility criteria, both clinical and social determinant, and engaged our IS colleagues to get our remote workers set up, most working from home. Had to have a fair number of EMR adaptations for documentation, had to increase access for some of our providers who were ambulatory only, and vice versa, and make sure that our virtual visit platform was working. We trained our staff virtually, and I believe had 2 total in-person meetings before we launched 1 week later and saw our first patient on March the 20th. So we initially set it up as an outpatient entity, partly because we just needed to hurry up. It was simpler. There aren't any regulatory or compliance issues related to an inpatient service. So we knew how to do that. And quite frankly, we weren't billing anyone. It was really just survival mode capacity management. We ran for several months. So we're starting in March. In September, we said, you know, we're in this for the long haul. We believe this is right care. We believe it fit into our value-based care journey. And as Dr. Lord mentioned, population health broadly. So part of our payer strategy, even we officially named the program from COVID Virtual Hospital to Atrium Health Hospital at Home officially. And also secured permanent staffing with 9 RNs, 6 FTEs of providers, and around 14 community paramedics. And then inputs literally from all over the system with pharmacy, respiratory, PT, OT, speech, palliative care, all that you might expect. In November, you probably know the CMS issued a waiver opportunity where experienced programs could launch a program and actually get paid a full inpatient DRG. In fact, CMS called us and said, hey, would you be interested in being in that first wave? We know you have a lot of experience. We weren't quite ready to pull the trigger in that moment, but in December, we were approved to enter the waiver program. However, that's right when the, I guess, second wave, maybe the third tsunami hit. And we were focused really on managing capacity. So we did not implement the waiver until March of this year. So we waited about 3 months to get through the January, February surge. During that time, we hit a peak census of 130 patients on service. That's why I have gray hair. On March 1, we did implement the waiver in 3 of our facilities. We now are live in 9 of our 10 region facilities under the CMS waiver. So we're being paid a full inpatient DRG for inpatient care for Medicaid and Medicare and several of our commercial payers. From the beginning, we engaged compliance, legal, regulatory, finance, quality, all of those folks to make sure we were, to the letter of the law and delivering inpatient care. Over the past 20 months, we've refined and improved our clinical and operational processes. As Dave mentioned, really great outcomes. Our patient experience data shows they prefer this. So would I. In August of this year, we were able to prove our financial viability, which means essentially we have a positive margin and have been able to prove that our cost is lower than brick and mortar. To date, we've cared for just over 3,800 patients in this model, saving about 14,000 inpatient bed days. And our hospitals run at about 115% occupancy. So that's important. My personal current work is that, but really turned toward advocacy, really on 2 levels. One is legislative. So working closely with our government relation folks at the federal level to get the CMS waiver extended by 2 years so that we have more time across the country really to refine the program and build our foundations and frankly prove outcomes, which is what the legislators are waiting for. And then at the state level here in North Carolina, we are a CON state. So there are a lot of issues of licensure and CON. So that's kind of where I'm focused first. And then secondly, around payment. So all of our payment is sort of at the mercy of the public health emergency in a way. So working with our contracting folks to secure ongoing payment, particularly for the commercial payers. So I know that was fast, but I wanted you to have some context for the real story, which is our clinicians. So I'll turn it over maybe to Nisha since she needs to be off first.
Colleen, you are amazing. Let me just say that. I always say that every time I'm talking to you. Hello, everyone. So my name is Johnnisha Brown. I'm an assistant professor in the family medicine department. And I also work at behavioral health for our system at Atrium Health. So I started in hospital at home in 2020. in July. So along with Dr. Mohannan. I believe you started a little bit earlier than me, but I'll let you tell your story. Really, my involvement initially was out of a need and also a want. So I was a high-risk employee in the Atrium Health System and really needed a lot of my roles to become more virtual for a period of time as we were all trying to sort things out and see where things landed. And so that was probably my personal need, but my want was also to still be impactful in the pandemic. And so I really sought out ways to change as much as I could my roles, and for my the people that I work with, changing their roles to virtual at behavioral health, more importantly. But then also in the family medicine department, I didn't want to just not be effective, and only doing clinic visits. And so really we're seeking out different opportunities to be more innovative, because in 2021, we have all this technology to be able to do different things. And that's really how I landed with talking to Dr. Murphy, who is a big part of this conversation as well, but will be standing in her stead today because she's internal medicine. And so just with those initial talks really began to be a part of the continued building of the hospital at home program. And so I've been doing it ever since July of 2020, and has it changed since then. A couple of things that I really enjoy about hospital at home, it's not very much different, quite honestly, than what you do in a brick and mortar inpatient, but I think it adds on extra layers in regards to taking care of historically marginalized patients. I feel like being able to have the patient more comfortable in their home setting creates a different experience for the patients. And I think that plays a big part in our patient satisfaction. Patients just, they feel more open to partnering with you when they feel like they have more stake in the game. And I think that's what hospital at home gives a patient. Also, you're able to partner with families more so than you are able to do in the brick and mortar setting because of different schedules and things of that nature. Pleasant surprise that I've seen is that what you're losing in the virtual setting is not very much. A lot of these things that we do in regards to our medical decision making, we do a lot in our head and with discussion with the patient. And so we use, the paramedics to fill in that gap for physical examination. But for the most part, I've been pleasantly surprised that it's only improved my analytical skills. And really it hasn't sacrificed the patient outcomes for the various types of, diagnoses that we treat. So very happy to be a part of this team, and I'm in it for the long haul because I do feel like it's very innovative, and I feel like it's a better way to care for particular patients. And it should definitely be a staple in family medicine. Last thing I'll say as well is that we as family medicine are so poised to be an impactful part of this type of program because we have one foot in outpatient and one foot in inpatient at all times. And so for some of our internal medicine colleagues, they did kind of struggle with understanding the logistics of outpatient. And I know Dr. Mohannan will speak to this more, but that is our world. And so we were able to, really bridge that gap. Even when we were trying to do prescriptions outpatient for inpatient care, we were able to, do those things and coordinate that care for our patients. So I just feel like, just family medicine in this space is much needed.
Thanks, Janisha. Swetha, go ahead.
Hi, I'm Swetha Mohannan. I'm the medical education director for Hospital at Home. I have actually been involved with Hospital at Home since March of 2020. Poor Colleen, she's had to deal with me for a very long time. So what essentially happened was I was high risk and I don't really do well not working. And so Slauson just kind of fobbed me off on somebody else and it worked out really well. I am by nature very much an inpatient doc. I run the inpatient service and I saw a lot of similarities. I saw a lot of opportunity, especially with our patients who had a lot of social determinants of health that obstructed care and obstructed follow-up. And so for me, a great deal of this was achieving care at home for our patients that weren't getting equitable care at baseline. So what I've been doing for the past year has been developing a curriculum as well as an elective for our residents, because education, this is the future. We're all going to be doing this. I think Oak Street Health, I think we have several small agencies in our neighborhood, as well as Rock the Block, like national agencies. I think that all of our residents are going to have this as an option. And I think that we will be under equipping our residents if we don't teach them how to treat patients on a virtual standpoint. And this is beyond just doing outpatient virtual visits. So that's been my first focus. However, given the last year or so, as I've brought faculty on, as I've done more teaching, I've also realized that this is a really good outlet for a lot of our practices that are not co-located. So for example, we have a level 4 trauma ED that we admit from, but like this is an opportunity for us to recruit those patients and get them to our community-based hospital. There are a lot of different opportunities here for virtual care that I think that we have undermined and not really fully understood. And I've been doing this for 2 years, so I understand it literally. Other than Murphy, I think I probably understand it the best. And it's been a real eye-opener to understand how much patients want to be at home, how much they really care about getting services at home, how much better outcomes are when they are at home, especially when during the pandemic, they couldn't see family and friends, but if they're at home, they can. So this has been a huge thing for us, especially as family medicine. We're also expanding. We just started surgery. We're starting OBGYN, which, I mean, if anyone can think about the uselessness of postpartum visits in the hospital, I mean, this is a gold mine for us. Like, why wouldn't you want to be at home after 24 hours of having the baby? But a lot of those things, newborn visits, we are doing weight checks. We are doing transition clinic, like, so patients that have left the hospital and are within the 30 days of needing like their med check, et cetera, and their med rec. I mean, this is a perfect place for where hospital at home can occur versus having patients stay in the hospital. So for me, the biggest thing is reducing costs, improving outcomes, and also allowing patients to be where they are the most comfortable. I would want to be at home. Colleen would want to be at home. I know for sure Dave would want to be at home. Janisha is at home. That's because she's smarter than all of us, but that's a sidebar. But I do think that this is a thing that we're really overlooking for what patients want for satisfaction, as well as for improved outcomes. So I'm not going to talk anymore. I'm just going to let you guys ask me questions, but I'm all in. This is one of the best things I've ever done with my career. And the other thing that I just would like to say is that I've spent my entire career working with HIV and Hep C. This is an mRNA virus. This pandemic has taught us a lot, but what it has really taught us is that we need to be nimble. This is the most nimble and movable, flexible way of delivering care I have ever done. And I've been doing this for 20 years. I know I look good, but that's just because I do a lot of sunblock.
Yeah.
But this is really, like, I mean, seriously, to be perfectly honest, like, we got to meet patients where they are. That's where they are, and that's what they want. And we've got to do this so they come back to us. Thank you.
Just a couple quick things to add to that. I know all of us probably had the same experience with the pandemic, that before the pandemic, family medicine, they being the rest of the sort of medical center, never really kind of recognized our value or thought we could do very much. And suddenly with the pandemic, they needed us to do everything everywhere. Colleen mentioned back in December, a year ago, when we had the biggest surge, I think we got up to like over 100 beds. Part of that was because I asked every member of my department to work 10% more than they were working. And everybody worked 10% more. Some people did more clinic. A number of people switched over. They completely stopped clinic and they went over and they did nothing but hospital at home. And so we were able to, for quite a period of time, provide that higher level of care. It wasn't easy, but it was really valuable. And I think it really showed the medical center what we could do. And I know we mobilized and did more than I really think any other department really in the whole institution was able to do in the pandemic. One other thing that I want to add, just recently happened, Colleen mentioned that they call it hospital at home, but one of the big, Rich and I, we always have these bad weeks, and I had a bad week the week before last, and I was getting all kinds of grief because we have patients that are stuck in the ER in one hospital, and we don't have room to get them to another hospital, and nobody wants to take care of them in the hospital, and my faculty are still working 10% more, and they wanted us to do even more, and this was just really semi-traumatic thing. We ended up solving that. The patients that are sitting in the ER that don't have beds are now actually being taken care of by hospital at home. So it's not even hospital at home anymore. It's now hospital in the ED. It's hospital in the airport, whatever. It's basically wherever you can put people to get them there and take care of them. I'm sure what's going to happen with these. There was an article in BMJ just a couple weeks ago that said people stuck in the ER for longer than 12 hours, mortality goes up by 1 or 2% every hour that they're still there. With hospital at home, we can take care of them there. We can probably discharge them from home from the ED. They never go to the brick and mortar hospital, and then keep following them at home again. So the opportunities for this, I think Faith mentioned, we're doing OB, we're doing peds, we're doing post-op surgery patients. So there's a lot to this, and clearly I can't agree more than everybody that this is going to be a standard skill for family medicine. So go
Could
ahead.
I just add one
Go ahead,
thing to
Colin.
add to what Sveta said about holistic care? She didn't use that word, but I learned it in nursing school 4 decades ago, and we kind of never did it. I think family medicine did it better than anyone. The patient that presents to brick and mortar, we take care of what brung ya, as my grandma used to say. It's a diagnosis, and we go after that. And we get some social determinant of health information as we interview a patient and we care for them. But there is nothing that can replace a visualization in the home of how a patient actually lives. And so there's kind of some fake news out there, actually at the federal level, that this program is only for the elite, that this is for the patients who have means. Nothing could be further from the truth. We see this as part of our health equity strategy, part of our rural health strategy, where you actually can see for yourself how well or how poorly our patients live and address the whole patient, not just this physical disease. So, I mean, I actually get goosebumps when I think about this. There is no better opportunity to truly deliver holistic patient-centered care than actually going to where the patient is.
To be perfectly honest, we're actually using this as part of the home visits that our residents are required to do, because I have learned more about my patients in the last 2 years. And, you know, other than Dr. Murphy, like, I think I've been doing it second to her as long. And I have learned more about my Middle Point Safety Net Clinic patients than I ever hoped to learn. And it has benefited me tremendously as their provider. And so we are actually using this as part of our educational training. We're trying to get this accounted for home visits, because when you see a patient in a trailer with a hole in their ceiling where you can see the sky, you understand a lot more about why they're not getting their prescriptions. Like, these are game-changing events that happen in a patient appointment. And I think the other thing too that we really don't discuss is that we serve a very diverse community. We serve everyone from our, lake dwelling, have a boat community to our EBT receiving patient. And that is our privilege and our joy to treat those patients. But I think it's really important to have patients understand, and to have our residents and our learners and our colleagues understand that, like, what you see in the hospital is not the same as what's happening at home. If you can get them their medicines at home, it's not the same as getting their medicines at home. Like, they get them in the hospital and then they go home and we don't know what happens to them. It's been a tremendous learning opportunity. I've loved every moment of it. It's not been easy, full disclosure, but it's made me, I think, a better clinician. And then also, I think for my learners, I think it will help them be better clinicians as well, especially because I work in a safety net clinic. Thank you.
I'd like to add a point to that, Dr. Mohannan, as well. So flipping it on the other side, we usually have this sometimes preconceived notions about patients based upon how they come into the clinic, right? And for the provider or for the learner, seeing a patient in their true setting that actually might be better than what you have in your mind in regards to whatever biases that you have attached to that patient or their demographic or whatever the case, or their insurance abilities to pay, you know, it might be completely different than the experience that you actually get when you're seeing them with their family and also in their setting. So that's also been a pleasant surprise, because you can only assume if you can't see.
I think what I feel is that this opportunity for our learners, for us as educators, as well as for us as a practice, what we've really come to understand is that our patient has a 360, and we don't understand what that 360 is. And this allows us a window into that 360. I will never give this up, because I get to be in patients' homes, and it has changed everything for me. And I've been working at Middle Point for 20 years, but it has changed everything for me. And there's a part of this that I will not give up because of what it has brought, in terms of richness and experience, and then also what I'd like to teach others. Thank you. I'm going to stop talking. I'm done.
Well, thank you guys for a whirlwind tour of that. And we'll see if there's questions. I have a couple I can throw out as well. I will say to the group, up in the Winston region with Atrium Health, we came a little bit later. We couldn't get the waiver. So we had to, sort of what was being mentioned, we created a hospital to home. So trying to move people out of the hospital at a much earlier stage than was happening. So everybody gets an observation stay and then moves out. I'm gonna throw in one question just to throw up, and then we've got some over here. Sam's talking about raising hands, and we'll get her to help call on folks with this. One of the things we were hamstrung with in our region, still now trying to do it, is the paramedic resource. Clearly RNs were, like non-existent, trying to find them. They're in the hospital, the paramedics. It sounds like, if I heard you correctly, you already had a paramedic program going. So you had those paramedics, you could do it. For the 3,800 admissions, how many paramedics on your team do you have?
We're now at 8. Oh,
no, go ahead, Colleen. I was going to call on you. So go ahead.
We're so excited. We have 18 FTEs dedicated to this program. There are a few more than that in the overall program that do some other work, chronic care in the home, et cetera. But we are one of the few in the country that did have that to start. As you said, Dr. Lord, finding RNs, we did have a little bit of support from our home health nurses. But what I have found, I think we've hit on the best model. Nursing under the CMS waiver, and as long as I'm responsible, will still have the same responsibility they would have in brick and mortar hospital. The plan of care, oversight, connecting the dots, all of what nurses do in brick and mortar. We have a 24/7 virtual nursing team. But I think community paramedics are ideal actually in this scenario, because I've ridden along with them. When that patient is decompensating or destabilizing, they're trained to deal in an emergency. Home health nurses are amazing, but usually not around the emergent or even urgent. It is wound care and amazing stuff. But I've watched them go in, start an IV, crank up the oxygen fearlessly. So I really like the combination of RN oversight with, as I think Sveta said, the eyes and ears, might have been Jadisha, of the rest of the care team. They're the ones that are in their eyes, ears, hands and feet even to actually deliver, but on behalf of the care team. So I think it's a nice mix. I think my ultimate sweet spot would be that the RN does the initial in-home assessment, and then from then on, they remain a virtual. So that's kind of how we were lucky.
Thanks.
Some states, by the way, do not allow community paramedicine to practice. It's outside their scope in this model.
So I was going to say, I think that's actually really important. I think our providers came to trust community paramedicine in a way that I've not worked with them before. I mean, before this, I had no exposure. as well as with nursing. I mean, I am an inpatient doc, but how much do you trust your floor nurses versus when you get to know them? I think that understanding the team, understanding what they grasp of the situation has been really key. Our biggest issue, honestly, has been staffing with physician providers and with mobile medicine providers, because while, I'm going to be really honest, like when we surged and we just tried to tamp the wave down. And I think that's been our biggest issue. We have struggled with staffing, as well as every other service has struggled with staffing, primarily because we are, dealing with the pandemic. But I could not do it without my mobile medicine partners, with my RN partners, without relying on someone else's eyes, ears, hands, feet, et cetera, on the ground. And I think that the team concept, especially given, PT, OT, and social work being involved, and pharmacy, oh my God, I cannot tell you how important pharmacy has been to all of this. I think we could not have done this without a multidisciplinary approach. And I think that is what has made it a game changer for us, because we've recognized that the multidisciplinary approach is key. Nobody is more important than anybody else on the team.
Great. So I see a few hands up. I'm going to call on Michael Jeremiah first, but you guys need to know I'm kind of frustrated with him because I had somebody interview and they told me his office is way nicer than mine. So just be aware of that, so that everybody knows that his office at Carillion is way nicer than down here. So go ahead,
I'm
Michael.
just saying, I got a room on the third floor in my house.
Yeah.
Thank you, Rich. I have, this is fantastic. So thank the team so much. Really, really exciting stuff. And I agree with you. I think this is going to be the wave for so many of us. So we're really glad to get some glimpses into it. I have a million questions. I can't ask them all because I have too many colleagues also that have questions. I'm going to boil it down to two. One is just, how do you have the connection for some of your patients who may not have bandwidth or the hardware? And then the second is, could you spend just a couple of minutes, either Dr. Mohannan or Dr. Brown, and just take us through how you do your rounding? I mean, like, just kind of telling us how you're working through that, because I think that visualization, it would lend itself to a video too, but just would help us tremendously.
So I can speak very briefly to the connection. I have struggled quite a bit this last year with connecting to patients when I couldn't see them in person. Something about this virtual platform, because there is a human being in their home who is talking to me, who is talking to them. There is there's been an astonishing amount of connection and human connection. Like, oh, I actually work with the doctor because I'm seeing my own patients. I'm seeing patients that are seen in my clinic. It's been very gratifying to do that because you're serving a catchment area. And I think that's what really helps with it being community and local. And I'm going to let Dr. Brown speak to this as well. But the other thing that we've really done is we are always on. There's always family medicine involved in this pot. So if you go any 3 or 4 weeks, there's a family medicine doc on. They are seeing some of their own patients. They are able to say, oh, I see that your doctor's on my hallway. And I think that creates a great amount of trust and buy-in for the patients. I actually had a patient, which several times, where I'm like, I trained your physician. And it's been a tremendous ability to say that. The other thing that I would also say is that the technology has advanced much more than we actually think it has. Using Agnes, using the stethoscope, getting studies, doing imaging, it's much easier than you think it is. And we've been very fortunate because almost all of our sites are close to a facility where they're able to get imaging if they need it. And so we've been able to actually do true inpatient care. Dr. Brown, I'm sure you have something to say. I'm just going on and on.
Oh, no, you're fine. So I piggyback everything, ditto everything that she said. So going backwards a little bit, and I'm a little bit more techie, I think, probably than the other providers initially in this space. But so this is really exciting for me. So the paramedics own the hotspot. So you don't rely mostly on the patient's ability to have Wi-Fi or anything of that nature. So they bring a laptop in, and they can also access the video platform via the paramedic's phone. Okay, so the paramedic brings in those resources. The only thing sometimes that can be a challenge is the actual, Wi-Fi in the area as we're going into more rural areas in regards to that hotspot. So that at times can be a challenge. But then in those situations, we do use the telephone, either the paramedic's telephone or the patient's telephone. And then our backup has actually become Doximity with the video. It's still a confidential platform. So if for some reason, let's say I need to contact a patient, actually this happened yesterday because we downloaded some new video software and mine was not accepting the software on my laptop. So I had to use my phone, and I let the paramedic go ahead and keep going with their schedule. And I talked to the patient via Doximity video phone call on their phone, and it was in between 2 visits. So just to go into the next part of your question. So we kind of have this setup where there is a supervising provider every single day called a quarterback. And that quarterback, initially, they own the whole patient list, the whole census. They are the ones that divide up the patient census per providers. A message gets sent out early in the morning. It's a 7 to 7 shift. A message gets sent out early in the morning to go ahead and review the schedule for the day and review your patients. And then you have probably about a window from 7 to 8 o'clock in the morning, 7 to 9 maybe, to review your patients for the day and make some initial kind of plan, whether you need labs, if this patient's going to get remdesivir, whatever the case may be, to be able to do that initial conversation. And then around 9 o'clock or so, that's when all the calls start coming in for the video conferencing for the first visit. And all patients, for the most part, get 2 visits a day. So I like to call that time CP storming, the paramedic storm time, because sometimes you can kind of get calls at the same time. And so you kind of have to say, I'm with this person, but I'll follow up with you as soon as I get off the phone. So it's really helpful to have that time in the beginning of the day to really create like a skeleton framework for each patient. And then you just continue going until you see the patients. They usually see a provider 1 time a day, but like I said, they get those 2 visits. If you need to follow up with them in that second visit with the paramedic, you can. And then, so after you finish your visits, it's probably about 2 or 3 o'clock, depending on the amount of patients you have. We can carry somewhere between, yesterday I saw 14 patients with different paramedics. Sometimes obviously in surge, that was a lot more. Some days it's been less, as our census has changed, but after you finish that, you're continuing to follow up with the nurse, social work and, radiology to, continue on your plan like you would in the brick and mortar hospital. And your shift normally ends around 7. Mohana, did I miss anything there?
No, I think you did a great synopsis. The only 2 things that I would add is that when we are thinking about learners, we want to be appropriate and make sure they have 10 patients at a time like they would if they were in brick and mortar. We don't see these patients as this kind of like how we would be if we were in brick and mortar. Like, there are X number of patients on a Saturday, and past that, we just see them. These are our patients. So I think that's a huge mentality switch for a lot of our faculty. I also think that it's important to, when we have learners in this space, to have teaching there's a lot to be learned here. Like, as someone who's been working with mRNA viruses for the last 20 years, like, there's a lot to be learned. And even just managing your staff, telling a MIH or a mobile medicine person, I've got 4 stacked before you, which is what I say. I have 3 or 4 patients to see before you. Don't go in the room yet. Don't go in the house yet. Understanding contact precautions, understanding what it's like when you have other services involved. I think these are really important things. And I think that we're striving to teach this, but also striving to keep our people safe. And I think they recognize that.
Thank you.
Thanks. Dave Frakel.
I like your background also.
Yeah, your passion for this is contagious. So I think you have a very receptive
Because
audience.
it's awesome.
This, My question is, how do we retain the relationship of the primary care medical home? Because we could do this in a way that just brings a whole other team. Even if a family physician is a hospitalist, they may not have that long-term relationship with patients. So it seems like this is an opportunity for us to really bring the primary care medical home into this care and engage them. Was that part of the intent or strategy? Or if not, how could we make that an important ingredient?
I'll start and y'all can follow. About 3 years ago, we implemented a process where every single admitted patient gets a post-hospital discharge appointment with a PCP appointment made in hand before they leave the building. And so that was already hardwired. It doesn't perfectly connect the dots. As you know, the no-show rate is relatively high, but we were able to just translate that process so that every patient discharged from hospital to home is in hand, literally. They have a discharge appointment based on acuity and risk for readmission, how far out that is. And it does help. The other piece that I think is really important is a good chunk of our patients do not have a PCP. So we get them one. We make sure they have a PCP and an appointment in an appropriate time frame. It does stop short, though, of assuring that a relationship gets established. So I agree with you. I think that's the next frontier, is how do we really create a seamless system of care? And I think that's done through some other work we're doing at the system level around care coordination, care navigation, and looking at how we best use care managers, social work, and all of that to make sure we don't lose sight of the patient wherever they are in the continuum of care. And frankly, I don't think health systems do this very well today.
I would also say that family medicine as a specific discipline is uniquely focused on this. You know, womb to tomb is what they say. And I do think that there is a specific focus around this. It has not been easy, but I will tell you that, and Colleen can speak to this, and I know Dr. Murphy will speak to this, when family medicine is on, we are OCD about what's the follow-up appointment, what's the follow-up appointment, what's the follow-up appointment. And I think that that is a very important aspect of this, but your health system is where you're going to go for this. This is where the health system really needs to step up and declare a management network where they actually care for patients who are otherwise just kind of wandering the earth. But I will also say that it's been really great to plug patients into care who haven't had PCPs, especially my like 18 to 25-year-olds, because God only knows what they're doing. But I will say that it's been really great to say, like, you know, you need a pap smear. And they're like, what is that? And I'm like, oh God, let me get you an appointment. It's required a lot more interacting with the community, and I think that we'll get there eventually, but our health system has to really support that. And that's where the gap is. Dr. Brown, do you have anything? I'm sorry.
The only thing I'll add is that I feel like in this space, we are able to do more of a warm handoff than what you're able to do in the brick and mortar setting. Absolutely. You know, we have patients who, you know, you're actually seeing what they would be like, you know, after, you know, being, you know, 13 days in the hospital. What are their actual needs? And so we're really able to communicate that a little bit better across the lines from inpatient to outpatient. You know, I've, you know, assumed some patients from hospital at home, they become new patients in our clinic, and definitely that rapport is more there than, you know, a patient you might have met in brick and mortar, because we've had more confidential conversations probably than you would normally have, private, more intimate conversations than you would normally have in the brick and mortar setting. So I think in my mind, it's just a warmer handoff, and definitely an extension of what we can do in family medicine, as opposed to replacing what we have in the outpatient setting.
The other thing to add to that, Dave, is that it's really evolved. Early on, it was just COVID and it was just adults. Now it's COVID and adults and other illnesses, but it's also now becoming kids and post-surgery and OB. So I really think where it's going to evolve is that our family medicine department, right now, hospital home has some of the internists are part of it. They do shifts and our people do some of the shifts, but I think it's going to be not that long before our department has its own hospital at home service. And we're separate from the internal medicine hospital at home service. And we will keep that patient-centered medical home with our own patients, and make it even better because they won't necessarily go to the hospitalists. They'll go to our own people who sometimes see them in the office, but sometimes also take care of them at the hospital at home. So I see it actually adding to that.
Yeah, I think, Dave, we're struggling with that up in Winston as well, as far as even with the hospital to home, if we transition them out, how many of these visits do you need to be doing to be competent with it as well? Because there is a skill set there, and trying to figure out that for, practice with 10 providers, if they're admitting X number of people into it, if they're only getting 2 or 3 per month, can everybody in the whole clinic? And so we're going to work through that as well. So. All
So
right,
if
and
I
then-
can just speak to that, we have aggressively pursued competency, and I know Colleen has heard me ad nauseum about this, as well as Dr. Murphy, but we are being very careful about making sure that our providers are competent. I think for right now, with the census that we have, we just need to be part of the solution and not the problem, which is where we are. And, obviously in an ideal world, we will have our own service and everyone will be incredibly talented and trained on this. But we're actually following the guidelines of virtual critical care. And Colleen can speak to this further because she knows that myself and Dr. Murphy have talked about this ad nauseum. But we are very clear that everyone who is in this space needs to be comfortable, have significant clinical acumen in this space, and that this needs to be a place where they are good with moving forward in an innovative way. And I think that a lot of this has been handpicked, but I think as we expand, we'll see what happens. And I'm going to be really honest, I'm an inpatient doc. Not everyone inpatient is right for this. Not everyone in virtual is right for inpatient. We need to just recognize what our talents and strengths are, and we need to pursue that, but also teach that, because we will have residents like that as well. And so I think we're being very careful about that. I'm not rushing this. I have no interest in rushing this. This is going to be, it's a labor of love, but also more importantly, I'm not willing to compromise the standard of care for any patient under any circumstance. And I know Dr. Brown, Dr. Ho, and Dr. Murphy are of the same accord. So I agree with you, but we are mandating certain amounts of competency. So that is, and I'm happy sharing that with you if you'd like more of that information.
Great. So we've got about a little less than 10 minutes or so left, I think, Sam, right? If I'm reading this right. I want to get David Rushlow, and then I'll go over to Emily. So David.
Actually, I think Emily was before me, but
Okay.
yeah, Emily, go ahead.
Yeah, Emily, jump in. Sorry, just trying to.
Thank you. I appreciate that. That was very nice of you. I'm one of the associate program directors at UT Southwestern in Dallas, Texas, and we've been approached to potentially help out with a hospital at home program and implement it not only to our department, but also our residency training program. I know you all touched briefly on kind of the logistics of the day-to-day, but I was curious if you could dive a bit deeper into how you incorporate this into the residency program. Is this something that residents only do as an elective, or can they dedicate their whole inpatient training as part of their training program to this experience, other than just the nursing home visits or the home visits that you implied? I was curious if you could touch a bit more on that. Thank you so much.
So we're currently doing this as an elective, primarily because it does interfere with our staffing. I mean, obviously, because of the pandemic, we've all had staffing issues. We are rolling this forward in 2022 as an elective, but also because, to be fully transparent, I want it to be a true educational experience, similar to what Colleen said. I want them to go with the paramedics. I want them to see what the pharmacists do. I wanted a truly immersive experience. We've gotten a lot of interest for the next 6 months and also the other thing too is the competency. We checked in with ACGME and they said that you need to have 16 to 18 shifts to quote, account for a competency. And I intend to do this fully credentialed. And so we are working on that as an elective and then perhaps roll it in, as I'm sure it will happen going forward. Currently, we have a lot of interest because a lot of our residents want to stay in the area, but they don't necessarily have jobs in the area. And this will allow them to make an income and, you know, have a little bit more flexibility. So that being said, doing it as an elective in the early months also allows us to troubleshoot a little bit. And we want to make sure that when we have credentialing, that we can be credentialed, because this is not going away, and I want it to be perfect when it is implemented. And I know that Slauson will just be like, nothing is perfect, but that's who I am.
Let me add one other thing as well. So this is, you know, as you're thinking about the residents that are appropriate for, you know, training in the hospital at home, this is not for intern level. Really, those milestones are the higher level milestones as we were planning out that curriculum. So these are residents who already have obviously the core, you know, foundational aspects of taking care of, you know, inpatient patients and critical care patients and how to triage that and assess it appropriately. But then moving away from just the medical knowledge component, they really need to be in the higher level of interpersonal skills, and also just understanding how to connect with other allied health teammates in an appropriate manner. So they have to have some level of systems-based practice to be able to function as they need to, because they're not independent, they're still with a provider, but to really be able to do even kind of the initial kind of, you know, partnering with the patient and the team, you have to kind of have some basic core understanding of what goes on in brick and mortar and how to apply it to this space.
Thanks.
I would say that, yeah. So I would say that actually for CCC, if you're looking at those, this is all 3 and 4 for MSK, communication for system-based, and then, and correct me if I'm wrong, Dr. Brown, but also medical knowledge. Like, so this requires higher level. So we're not offering it to anybody but third years at this point.
Great. Thanks, guys. Dave, I want to make sure I get it back over to you. Thanks.
Yeah, thanks. And I almost put my hand down because David Rakel asked the question that I was thinking about. So in our organization, this is being implemented through hospital medicine, not family medicine. So it is so great to hear this work, and proud of our family medicine colleagues and your work on this. I can't think of a better specialty to do it, frankly, but not the case here.
We're doing it. We're doing it.
Yeah, you are, and very well. So I actually have a meeting with the group later today, so this is great timing, and I'm very interested, at least in those handoffs between the inpatient encounters. I guess I mean, it gets so blurred here, doesn't it? And the outpatient team, and it sounds as if, Colleen, you mentioned the usual and customary post-hospitalization visit that we're all doing, but I wonder if this allows an opportunity for more transformative handoffs between more sick, less sick. I'm not quite even sure how to even state it anymore. Is it, can it stay virtual? And maybe even talking about how to hand in. So if I'm seeing a patient, how do I get them into the hospital at home? And maybe I am seeing them virtually. And so the patient never has to leave home from like an outpatient visit with me to an inpatient visit. So any ideas that I could use in my meeting later this afternoon?
Well, first, I have spent a fair amount of time with your colleagues at Mayo. We actually have a lot of common goals around our programs. And I got to say, I love my family medicine colleagues, but our hospitals group does play a major role in this program. They're not in it. So I don't want to misinform. But the CMS waiver, unfortunately, requires the patient must come to us from an ED visit or an inpatient stay. We have argued loudly against that very directly. And frankly, the CMS people agree with us, but they wanted to assure this patient was hooked to a hospital for a safety net. But just yesterday, we had a 90-year-old gentleman who needed to be admitted to hospital at home, and the only way in was to go to an ED. And we all know that that would not be a value add to this patient. We could have very easily admitted him to hospital at home from home, but that is a next iteration, hopefully soon, or a physician office. There's really, in many cases, no value of sending the patient to brick and mortar to send them back home. So that's one thing. I agree, this handoff situation, I'm a big proponent of improving our transitions care. We healthcare in America, not just us. We don't do it well. Patients fall through the cracks between our incredible venues of care, and they're left to figure it out on their own. And we've got to improve how we transfer care from one provider, one service to the next. And as we've talked about, the visibility of how the patient actually is living, we're actually kind of in on a transition right there. And then as I think Janisha said, how lovely to know this patient has food insecurity, or there's a hole in the roof of the trailer. We're actually going to implement a program partnered with, oh goodness, it just left me, Habitat for Humanity, where we're in the home, we see the risks that might keep a patient from living in their home, or what might not allow the patient to stay in their home. And we can address those. We could put a support bar beside the toilet. We could build a ramp. Increasingly looking at how we can help patients transition and live their best life, frankly, outside of a physician office or a hospital, because that's mostly where they're not.
And I think that to Colleen's point, I think what we've really worked very hard on is patient selection and making sure that the patients that are in our hospital at home are the right patients to be in hospital at home. It's not for everyone. I think just like not every provider is right for hospital at home. I think we've really been careful about that. But I will also say that it's been very illuminating what we've learned about patients and what we've been able to provide that we probably wouldn't have if they just stayed in brick and mortar facilities. So I think there's a lot of scope, especially for family medicine, given, that we do a lot of, and for hospitalists, because I'm kind of a hospitalist also, but just to be really mindful of what we're sending patients home to. I will tell you that and Colleen knows this because she hears about this from me at least once a week, but I am really into having patients admitted directly from clinic. I understand we don't have the waiver, but it would avoid an ED charge. It would avoid a whole bunch of finances and difficulties, but it would be a tremendous add, because if I can direct admit to brick and mortar, why can't I direct admit to hospital at home? And so I think that's the next phase of what we're going to do, especially for our patients who are underfunded. I think it will be a tremendous resource. And I think that's where we're going next. But can you imagine, like, if it were you or me, like if I went into the hospital with like a dark toe, I would just rather go home than have to go to the hospital and do a bunch of crap and then go home. I'd rather just go home. So we're trying to do this from an outcomes as well as cost saving perspective, but more importantly, we want patients to be happy and get the best care they can. And we're doing this from a very patient-centered focus. And I know Colleen agrees with me on that, because Colleen and Janisha are much better people than I am, and they are very patient-focused. Thank you.
So I've got it right at 1:59, and I'm sure, like a lot of folks, other folks have meetings. I want to thank the group from Charlotte for spending the time and at least sharing your wisdom with us, for sure. Great opportunity. Looking to see more playbooks come out on doing this to help the departments around the country as we try to think about how we educate around this, and then how do we bring it into our clinical sphere. I will say, Dave, for your group, the one thing we've done with our hospital to home is that once they go into the hospital at home program at Wake, generally within 2 to 3 days, they're questioning, is it time to get them back to primary care? And so we sort of said, really start assessing that. One, to open up capacity, right? Because if they're hanging on to them too long, just like our inpatient facilities, our hospital at home program can get filled up. So no right answers right now. So thank you again. There's a survey if you want to click the link that Sam put out there. Watch for more hot topics to come. If you have something you want to hear about, we're a committee that represents the membership. You can email me or Sam, and we'll take it back to the committee and see who has expertise that we can bring and share. Thanks so much for spending an hour with us on a Friday. Thanks for pulling it together, Sam.
Happy holidays. Thanks.
Thanks, Rich. Take care.
Thank
Appreciate
you.
it, guys.
everyone.
Enjoy your
Thanks for your
holidays.
service.